and welcome to my IVF Answers and our IVF webinar. And welcome. It's great to be here with you again. I hope you had a nice, longer weekend as well, and of course are ready to learn a bit more, but also have a look at some other cases, real life cases. As you know, our project right now is all about success stories. And tonight we do have a very special guest, Dr. Elena Santiago. You can see her right here. She's back with us. She's been with us before. She had some webinars. I think there were 2 previous webinars with you. So welcome back. And how are you feeling, Dr. Elena, tonight?
Hello, good night to everyone. Thank you so much for inviting me again to my IVF answers webinars. Very delighted to see you again, and well, try to learn more and more every time.
Exactly. Of course, that's why we are here. And as you know, we will start with the presentation. We will be focusing on low ovarian reserve tonight. And Dr. Santiago has prepared a case, and she will walk us through the case. And of course, we'll tell you all about protocols, what was planned, what was the outcome, etc. So stay tuned, have a look at this. But afterwards, don't worry, your favorite part will start. We will have time for your questions. So as always, you can do it now during the presentation or later on, and Dr. Santiago will answer all of those questions, so don't hesitate. This is your time. Remember, this is anonymous, so any questions you might have, you can do it and get that free advice, of course, as well. And let me just add that Dr. Elena Santiago, she is a gynecologist and fertility specialist at Clinica Tambre in Madrid. And so another team member from Clinica Tambre has joined us. So thank you so much for being with us tonight and, well, presenting this definitely interesting topic. And I'm all yours right now. I guess we can go ahead and start with the presentation, okay?
Okay.
Excellent.
Let's go.
Thank you so much.
Thank you to you. All right. So again, good evening to everyone. Today, as Caroline told you, we are going to talk about low ovarian reserve, and we're going to present a success story at our clinic. So first of all, what will we cover today? We're going to first see the definition of what's low ovarian reserve. Then we're going to present the general description and situation of our case, see how we did the diagnosis, the protocol and procedure of the treatment, how the embryo transfer was done, and finally, how the pregnancy was achieved, and the conclusions to all of this. So, very important in fertility, the meaning of low ovarian reserve. The definition of this is, well, we have to be aware, this is very important, that women are born with all the eggs in their ovaries. So we should have about, let's say, 2 million eggs at birth, which, and this number will be decreasing through life. So, for example, the 2 million we had at birth will become only 400,000 in the puberty. That's when the fertility is going to begin. From there, each month, we're going to be losing not only one egg, which is the one that we ovulate, we're going to be losing loads and loads of eggs. So, to have an idea, this is obviously numbers around what each person should have. So, for example, when we are 37 years old, we should have around 27,000 still eggs. But the thing is that here, there are lots and lots of people nowadays with low ovarian reserve, and as well, the egg quality obviously decreases. At the same time, the ovarian reserve will decrease, no? Obviously, in menopause, we still can have leftover eggs at our ovaries. They're about 1,000, but these are no more going to be available because the ovaries are not going to be responding to hormonal stimulation. So, I mean, we have to be aware of this, obviously, always, because it's absolutely different to the situation in men, as they do produce new sperm each 3 months. So in women, what we know is that there is no new production of eggs. Very important too to know what are the factors that are going to influence in the ovarian reserve. So as I said, first of all, the time is like the greatest factor that is going to make us have each year a lower ovarian reserve. So age is absolutely a very important factor to take into account when we are going to do a treatment, as well as how is the ovarian reserve of each woman. No? It's also important to take into account that other things could affect our ovarian reserve, such as toxics. Obviously, women that smoke or take lots of quantity of alcohol or don't do very healthy habits during their life, obviously all of this is going to affect their ovarian reserve. Other things that could affect, obviously, is gynecological pathologies, such as, for example, endometriosis. These things, we have to take them into account too, because, for example, endometriosis, it could affect the ovaries. Having cysts is going to affect the ovarian reserve left over in the ovaries. If we had surgeries before, obviously in our ovaries, this could also affect the number of eggs that are left over. Also, how many eggs we have at birth or how many eggs will be left over during the years is affected by our genetical inheritance. So it also depends in what our mother had or our grandmother had before. We think there is an important genetical factor there. So, for example, if we see very young women having lower ovarian reserve, which they shouldn't, for example, women aged 30 years old with very, very low ovarian reserve, this is not normal. So let's say that it's important to see if in their families they have menopause or premature menopause in their mothers or in their grandmothers or in their aunts. So this is important to take into account. And obviously, another very important factor which affects nowadays a lot as well is oncologic therapies. No, if any woman has any cancer, treatments regarding chemotherapy or radiotherapy can affect as well the ovarian reserve. So knowing all this, the next step is get to know how we can calculate the ovarian reserve. So there are two important things that we should be doing normally in a first fertility consultation, let's say, because obviously to know the situation of the woman that wants to be pregnant, we need to know how is her ovarian reserve. So the first thing that we can do, and it's so easy, is to do an ultrasound with, we say, antral follicle count. So here we need to see the ovaries. Sorry, we need to see the ovaries, and here see how many antral follicles we have in each ovary. So a normal ovarian reserve should be between 10 to 20 antral follicles between both ovaries. This we have to compare with a blood hormonal testing of the anti-Mullerian hormone, where we should get a normal reference between 1 or 3.5 nanograms per milliliter. A high ovarian reserve is when we have more than 3.5 nanograms per milliliter, and obviously low ovarian reserve is when we have less than 1. So we always need to compare ultrasound with anti-Mullerian hormone, because sometimes the ultrasound, maybe we are not seeing good enough the eggs, so we are not counting good enough the antral follicles. Also, women, when they take, for example, birth control pills, sometimes we are not able to see loads of follicles, but they do have a good ovarian reserve. So that's why it's very important to compare the image of the scan with the anti-Mullerian hormone in blood. Sometimes also we can have results that are not very similar between the ultrasound and the anti-Mullerian hormone. So sometimes we do have to repeat the test, see what's happening, or have an idea of what could happen during a treatment when we stimulate the ovary. Maybe if we have, for example, a very good or a good antral follicle count in the ultrasound, but we don't have a good anti-Mullerian hormone, maybe here this situation is telling us something. It's telling us that maybe if we go ahead with an ovarian stimulation, even if we see a good number of antral follicles, not all of those follicles are going to respond to the treatment. All right, so there are many things to take into account before doing any treatments. So let's talk about our clinical case. It was a couple that had been trying to conceive during a year and a half. They came to our clinic. As I said, age is so important. So take into account that she was aged 32 years old. She had a normal weight, 57 kilos, no previous treatments, no diseases or current medication, and there was no familial background of early menopause. So at first, it didn't seem something related to her family. No, she didn't also take any toxics, such as she didn't smoke, or she didn't drink alcohol every day or several days per week, only occasionally. And her partner was also aged 32 years old, which also, obviously we need to take into account age of the male, but it's not so important as in women. No diseases as well, or current medication, or no familial background of interest. So first, I'm going to present what are the tests that we did to the partner. So we always do, as well as see how is the ovarian reserve in a couple. We have to see, first of all, how is the sperm count of the man. No? So we did a sperm test at our clinic, which resulted normal. He had, for you to have an idea, a concentration of 22 million per milliliter. In total, he had 44 million, which is quite good. The motility was normal, 58%. It should be more than 32%. And the morphology was just in the limit. It was a 4% of normal sperm, which is quite common. I mean, there are no men nowadays having, like, for example, 20% of normal sperms. If you do a sperm count at a fertility clinic, you will see that normally normality of morphology is around 4%, something like that. We did a karyotype to see his chromosomes in blood, because normally we do ask for karyotypes before doing any treatment. We think it's important because it's a very easy test to do. Obviously, if the karyotype is not normal, it's something that we need to know, first of all, because, well, if, for example, we have an abnormal karyotype, we should go directly for an IVF and do a PGS, right? I'm not going to stop here more time, but I mean, it's something that we consider important, not mandatory, but we do try to have all patients with a karyotype before doing any type of treatments, even inseminations, okay? And infectious diseases screening, which is obviously mandatory always, was negative for him. What do we do to her in this case? So as I say, first of all, see the ovarian reserve. So this time we had an AMH of 0.5. We said that AMH lower than 1.5 is considered low. So obviously this is not something normal for her age. Let's say that low ovarian reserve begins to appear most frequently from 38, 40 years onwards. So she was aged 32. So we're supposed to see a good ovarian reserve here, but this is what we had. She had an antral follicle count with a vaginal ultrasound of 1 follicle in one side and 4 follicles in the other side. So we had in total 5 follicles, which is low as well. We said that a normal ovarian reserve should be between 10 to 20 antral follicles in the scan. Her hormonal test is also important. This is not mandatory, but well, normally when we do have an ovarian reserve, we have high FSH and high LH. In this case, we had high FSH, which normally should be lower than 10. Here we had 15.2. So this is telling us as well that there is a low ovarian reserve. Her karyotype was done as well, was normal. We had a normal smear test. The infection disease screen negative. Normal blood cell count and clotting. This is something that we normally do as well before any treatment. And thyroid, also very important for pregnancy, was 1.01. So just for you to understand, comparing ovarian reserve with age. This is something that we've already talked about, but just to see in a graph, no, we can see here that AMH lowers a lot with age. As I said, 35, 38 years old, normally we have lower ovarian reserves. Antral follicles, number of antral follicles in the scan decreases at the same speed, we say, as AMH, okay? So here we are. And FSH, as I said, is another hormone that normally increases. It's the other way around as AMH. But it's more important to have AMH values than FSH nowadays. So considering low ovarian reserve in this case, but still, let's say we have an age of good prognosis and a normal sperm count of her partner, we decided to go ahead with an IVF directly, all right? A single embryo transfer, we always recommend it if we have a good quality embryo blastocyst, embryo on day 5 or day 6 obtained. So now we will see, but obviously if we have the opportunity of having a very good quality embryo, then we always recommend single embryo transfer to avoid more complications with, for example, a multiple pregnancy. Here, this graph is for you just to see that, well, with age, maternal age, miscarriage rate increases because of normally abnormal chromosomical embryos, and live birth rates decrease. So that's why it's so important to take into account, obviously, the age as well as the ovarian reserve. We have to consider always that egg quality is going to be lower with age. And this is something that we can't know doing a test. We can, as we've seen, calculate the ovarian reserve that we have, but we can't know egg quality because there are no tests for that. So we have to take into account always the age to see more or less the live birth rate per patient. So for the IVF procedure, as you know, we need to normally start a hormonal stimulation of the ovary to try and achieve the eggs during the egg retrieval, we say, and do the fertilization of the eggs with a sperm in the lab and leave the embryos for 5, maximum 6 days to see how many blastocysts we achieve. Then we do the transfer of the blastocysts achieved, as I say, only one normally, and 11 days after we do the pregnancy test. So in this case, I wanted to share with you the type of protocol that we use, the medication that we used. This is not something that has to be like this always, but well, take into account all the factors that we had in this case, we decided to do an antagonist protocol, which is a short protocol. Normally we go with this protocol ahead in nearly all patients nowadays. We then start medication normally between the second, third day of the cycle. In this case, was the third day of the cycle. And we use medication which is called corifoliatropine alpha. So this is one type of gonadotropin that we do like to use in low ovarian reserve. As I said, not always, but we do like it because with one shot, you have an effect for a whole week. And we believe that using this type of hormone, we're going to have the same effect absolutely during the 7 days. So this is important to try and grow the greatest number of follicles as possible. We had the higher dose, which was 150 micrograms, and also we put an effect of HMG. Let's say this is like LH effect to try and have as well the best quality of eggs as well as the greatest number of follicles. In the 8th day of stimulation, as corifoliatropin effect is done, let's say we have to add up another medication. So we normally add FSH recombinant, this time with a high dose, 2 to 5 international units. In total, we had 10 days of stimulation, which is more or less the average. And in the 11th day, we had in total 5 follicles growing. In the right ovary, we had a greater follicle of 20 millimeters, the other ones were small. And in the left ovary, we had also a good one of 90 millimeters and another one small. So I mean, in total, we had 5, but we have to take into account that of good sizes, we had only 2. We did a double trigger to provoke ovulation. This is using 2 medications. So what we do here is try and increase chances of having the maximum number of mature eggs as we can. As we had only 5 follicles and 3 of them were very small. We tried there if we could have more mature eggs. The hormonal blood test that we do on the day of the trigger, well, we had good estradiol. It was 868, sorry, not 868 picograms per milliliter, which is more or less good. And progesterone levels were high here. So we decided when progesterone is higher than 1 nanogram per milliliter the day of the trigger, it's preferable to do a transfer in another cycle, we say deferred, because implantation rates are going to be lower. So sometimes we can have a high progesterone because of medication. This doesn't depend in anything that we do. It depends on the response of the patient. So finally, we went for the egg retrieval. We did go for all the follicles, even if they were small, but we only achieved 2 eggs, which were the greater follicles, of course. Both of them were mature. This was good news. We performed the ICSI procedure, meaning that each of the eggs microinjected with previously selected sperm. And we kept embryos in the time-lapse incubator, which the one we have at the clinic is the Jerry. And next day, we saw that both of the eggs were fertilized, which is very good news too. I wanted to speak a little bit more about the time-lapse incubator because I think it's important to use it whenever we can. We are able to do all that. Also, I mean, for example, at our clinic, we have several incubators of this type. It's optional for patients, but we do recommend to use it always if possible, because we are going to have much more information about quality of the embryos. So not only able to see morphology every day, but also we can see kinetics, meaning that we see the divisions of the cells, that everything is going as it should. And as their other big advantage, let's say, is that as we don't need to take out embryos of the incubator to see them at the microscope every day, therefore, environmental conditions for embryos is going to be much more stable. And we've seen, comparing to traditional incubators, that finally the number of good quality blastocysts achieved is significantly higher comparing it to the traditional incubators. So here you can see a normal, let's say, step-by-step embryo culture day by day. In this case, the 2 embryos developed into blastocysts of good quality. We had a blastocyst, well, this is a classification, which is good quality. Normally, we have A or B, and pregnancy rates are very similar between A or B. Okay, so we achieved a blastocyst in day 5, which was a 3BA, and another blastocyst this time in day 6, which was 3BB. Both embryos were frozen for a deferred transfer, as we said. Obviously, we did freeze them because the embryos were of good quality. If we had embryos of bad quality, then they wouldn't be frozen, because we always do transfer of good quality embryos. So for the embryo transfer, we did an endometrial preparation with estrogens, 6 milligrams per day during 12 days. We start from a period. We do an ultrasound with a period, see that everything, the situation is resting, meaning that we don't have cysts or whatever. We start with estrogens. We do a second scan 12 days after. We saw in this case that the endometrium was quite good. We had trilaminar or let's say 3-layer endometrium of 9 millimeters. There were no dominant follicles in the ovaries, which is important because there are no signs of ovulation occurring spontaneously. And we started the luteal phase support, adding progesterone pessaries of 400 milligrams each 12 hours. And this has to be done 5 days before the transfer, so that we have the correct window of implantation for the embryos. The embryo transfer, as I said, we spoke to the patients. We recommended, as we had 2 very good quality embryos, recommended to go for only 1 embryo to the transfer. They agreed. And 11 days after, we did the pregnancy test, which became positive, with a very good HCG of 326. Let's say that good prognosis is 100 HCG or more. There were no fetal or maternal complications during the pregnancy, and 9 months later, a healthy baby girl was born. All this occurred in the year 2018. So now, this year, 2 years after the patients came again to the clinic because they wanted to try for another child, as they had the frozen blastocyst left over. We did again a very similar, or well, the same endometrial preparation, but in this case, the pregnancy test turns out negative. So what are the conclusions for today? As I said, it's very, very important to make always an accurate diagnosis and specific tests to each patient. So here we have to individualize each patient to make a correct assessment and recommend the proper treatment. As we've seen, it's very, very important to do an examination of both male and female factors, obviously. Age, as we've spoken a lot, is the most important indicator for egg quality, as I said, previous to an IVF. Even if we have a low ovarian reserve case, chances of success are going to still be good if the woman is aged less than 35 years old. And time-lapse incubators, as I said, are always recommended to increase the cumulative pregnancy rates. This means we're not going to have higher rates of pregnancy, which is each blastocyst, what this means is that we are going to have in total a higher cumulative pregnancy rate, because if we can achieve more blastocysts, then we are going to have more chances. We are going to have more embryos to transfer. So therefore, we are going to finally, in total, have more chances of achieving a pregnancy. And this is all for today. Hope that obviously it helped you. And now I'm open to all the questions.
So much indeed, Dr. Elena. It has been most helpful indeed. Brilliant presentation, and thank you for walking us through it. The case, of course, with all the details. And there are some comments here saying that definitely that was helpful, and we are very happy that we were able to see this and be a part of this presentation. And as you can see, lots of questions are actually coming up. So let's get going. Okay, so now.
Okay.
Time for your questions is up, so go ahead, type those in. Let's start with the first one, okay? Here it is. In your clinic, what and how many antral follicle count and sizes do you trigger at millimeters depending on age, diagnosis?
I don't know if I understand correctly the question. I think here they are meaning to tell how many antral follicles we are counting depending on the sizes. So there should be antral follicles when they are lower than 10 millimeters. But we do count all, because obviously, if, for example, we're doing an ultrasound during, I don't know, 13th day of the cycle, for example, we're going to have a greater follicle for sure in one of the ovaries, and we do count with that follicle too.
All right.
And depending on age diagnosis, I don't understand that part of the question, sorry.
Sure, Derek, if you are able to clarify, okay? Because the first part, I think it's correct, of course, but if you have any other things you need to clarify, then just let us know, okay? Someone is typing, so of course it might be Derek. We need to wait, but in the meantime, actually Derek had another question, so let me go straight to this one, okay? Let me just have a look. It's in regards to your presentation, okay? So if you can clarify this one, positive on 3BB or the first blastocyst in regards to the presentation?
It was in the first blastocyst, which was a 3BA, but honestly, it's so similar, as I say, A or B. Sometimes we do have perfect blastocysts like 3AA, 4AA, whatever, and maybe you don't have a pregnancy, and afterwards you try with another, which is 3BB, for example, and you can have a pregnancy. So it's not so important. But always, obviously, having embryos from A to B, not lower quality. Lower quality should be C or D, okay?
All right. Thank you for the clarification here as well.
You're welcome.
Okay, and sorry, Derek has one more, so let's go with this one. Do you trigger sooner given a low count?
No, no, the other way around. What we normally trigger or try to trigger when at least we have follicles minimum sized 18 millimeters. But obviously, if we have other follicles coming in lower sizes, we try maybe to wait a little bit more and see if we can achieve more follicles of good size. Let's say from 16, 17 millimeters onwards. In this case, as you've seen, we had 2 of very good sizes, but the other ones were too small and we couldn't wait more. So, well, as I said, 10 days of stimulation, 11th day, the day of the trigger, and we don't go for the trigger before because we don't think that this is going to help.
All right. Thank you so much indeed. I believe that was most helpful, and there was a thank you from Derek. So thank you for your questions. Interesting
Thank
ones,
you.
of course, as well. Detailed as ones. So thanks a lot. Let's get going. Some more questions are coming up. There will be plenty of questions. So thank you already for putting all those here. And let's have a look. Sam has another question. What would you advise for me? I have been through 2 rounds of ICSI, 1 normal stimulation cycle, 1 mild cycle each time, despite multiple mature follicle. Only 1 egg is graded at M2 both times. I am 38. My clinic has said it is my age. What would you say I should do for my next steps?
Okay, yeah. Unfortunately, Sam, it seems that here there's a, let's say, bad quality of the eggs. Obviously, it could be related to age and, well, other factors that many times we don't know why we have a bad quality of the eggs. So, seeing that with a normal stimulation cycle and a mild cycle, you have more or less the same result, maybe you could go ahead with another stimulation and try even in a natural cycle, maybe with a very low dose. But I mean, this obviously you have to decide whether you have strength to go ahead with it, because obviously you've seen that 2 times the result is very similar. So sometimes we can get better results, but it's very difficult to do something medically that it's going to improve that result. So here you have to see whether you want to try again, as I say, mild stimulation or even in a natural cycle, or if not, the other option obviously would be normally with donated eggs. We'll go for an egg donation directly, because there you will have for sure much more chances of pregnancy.
Thank you, Sam, for your question, of course, indeed. Thank you for your advice. More questions, as you can see, are coming up, and Derek has one more. Do you attempt a version of IVM or emergency ICSI?
Version of IVM, I'm not sure if I understand what you want here to say.
Again,
maybe
if
classic
you can,
IVF, yeah.
If you can clarify, sure. In vitro maturation, okay. In vitro maturation.
Okay. So in vitro maturation, yeah, I thought that maybe you were going there. We don't have that option nowadays at our clinic, because, well, you know that it's something still in study. Let's say there's controversial, or, well, yeah, there are different results. So it's something that we don't do nowadays still. And emergency ICSI, I don't understand what's this. Sorry.
Understood. Of course, this is not something that I guess you are also using at the clinic. But of course, Derek,
I don't think so.
If there's anything else you would like to ask, then of course, go ahead. Okay, let's have a look. As I mentioned, there are plenty of more questions coming up. Elizabeth has another question. Is there any cause for which the eggs that are fertilized do not evolve correctly after the first day? In my case, both times the egg develop in 3 cells, not the same in size.
So here it's very difficult, Elizabeth, to know the cause. Obviously, there has to be, or it has to be related to egg quality. We normally say that the first days of division, when we don't have good results, it's more, let's say, cause of the egg than the sperm. But obviously here we will need to see more details about male and female factor to have more information.
Of course. Understood again. Thank you so much, Elizabeth. And let me go to the next question, okay? Nuria has added, you don't do any tests on the embryo biopsy? If not, in which case? would you perform biopsy?
We do tests. We do loads of PGS nowadays, but in this particular case, we didn't advise to do it because as women was 32 years old, normally at this age, you are going to have at least normally 50% of the embryos healthy. And as the idea was that we were not going to have loads of blastocysts to, let's say, make a selection with the PGS, that's why we decided finally not to go ahead with a PGS. But obviously, it's something that you can always do, a PGS testing, if you want. But medically, let's say that in this case, wasn't indicated.
Okay, thank you for the question and of course the clarification. Okay, one more for the, sorry, in regards to presentation, did you transfer back-to-back cycle?
Back-to-back cycle, yeah, it was the next cycle to the stimulation. So obviously we waited to have a period, and we did do a scan with that period. We saw that ovaries were already resting, so we did go ahead directly with a transfer. But I mean, sometimes that stimulation could make that ovaries are not yet resting with the period, and we do have to maybe wait 1 more month to have a good situation and start the endometrial preparation.
Okay, again, thank you for this. And when did you start the antagonists?
So in here, we started in the 5th day because we already had one of the follicles was in 14 millimeters. So our idea is to start antagonists when we have at least one follicle of minimum 14 millimeters, or if not, another way is doing it in a 6th day of directly of the stimulation. We normally go, let's say we normally go for the first option, the 14 millimeters at least, because sometimes we do have patients that maybe have very small follicles during the first 5, 6, 7 days of stimulation, and we do have to wait a little bit more time to add the antagonist. In this case, 5th day.
Perfect. Again, thank you so much. It's lovely to see that everyone is keeping up, of course, and having some questions in regards to the presentation. Now we have a bit of a different question from Antalya. I had a failed frozen embryo transfer in natural cycle recently. Asked the doctor if the uterine lining was trilaminar on the day of the transfer. HCG trigger +7. No, it was not. Is it not a suboptimal condition for the transfer if the endometrium has no 3 layers? Thank you.
Yeah, I mean, let's say that optimity to go for transfer is to have the 3 layers, and obviously no signs of ovulation in the ultrasound. But for sure, I don't know if they did this, you have to check before doing the trigger that there hasn't been any spontaneous ovulation, doing a progesterone test in blood. So I don't know if this was done, Natalia, but obviously maybe if you have not, I'm not saying that's your case, okay, but if you are not having maybe the 3 layers in the ultrasound, you have to suspect if there has been any premature ovulation, for example. So no progesterone testing. So this is very important. Sometimes we do have endometriums that are not trilaminar and there hasn't been ovulation. That happens as well. We try and have a trilaminar endometrium always, but obviously this depends on each case. Sometimes even you can have ultrasounds where the angle of the uterus is not absolutely perfect to see a trilaminar endometrium. So this is something to take into account as well.
Excellent. Thank you, Natalia, for your question, for your follow-up and your advice. And of course, let's have a look. And Natalia, of course, says, Thanks for helping out.
Thank you.
Let me have a look. Of course, more questions are coming in, and the question that we have from Elizabeth is here. In which cases would you suggest egg donation in patient with a low ovarian reserve? I'm 33, 2 attempts of IVF with no results. My clinic suggests egg donation in Denmark.
Yeah, I mean, it's very difficult to put a limit. You're still very young, good prognosis, let's say. But it's true that normally after 2 failed attempts, if there is no other factors that are avoiding an implantation, for example, because I don't know if you had good embryo quality, if there's need to do any other testing, we'll have to see that. Depending on the case, yeah, normally 2 or 3 attempts, we do always recommend egg donation. If we see, for example, if that egg quality maybe is not so good as your age should be telling, no, before doing anything. If we've done 2 cycles and we see that egg quality is not good, then we do recommend, obviously, to go for an egg donation directly.
Thank you again for the clarification to this one. Okay, and of course, there is a thank you, of course, from Elizabeth. Thanks indeed. Okay, and sorry, just need to have this right here. Angel has another one. Thank you. Can this help with the person who has FSH 112.5, AMH 2.1, AFC 1, good immune, healthy person, body weight 68, age 40, good immune, negative smear test, hemoglobin 121. Anything you can advise?
Okay, FSH seems very, very high. I'm not sure if this is done in a good time of your cycle, but as I say, it's normally not important. AMH, I think you're talking maybe about picomole, not nanograms, because no, it's different. So I suppose 2.1 picomole is quite low with only 1 antral follicle. Even if you are very healthy, good immunity, good body weight, your age is not a very good prognosis, because obviously we can go ahead with a stimulation. We could achieve a follicle growing after stimulation. Maybe we can achieve an egg. Maybe that egg could fertilize, and maybe also for sure we can have finally a good quality blastocyst. But you have to take into account that getting there is quite difficult. Even if we have finally an embryo, chances of pregnancy are low because of your age. So here, instead of having, for example, 50% chances of success with 1 embryo, with each embryo, you're going to have around 20% chances. Because as I said, egg quality is going to be lower for sure, and there are going to be more abnormal chromosomical embryos. So you are in a situation where you could try with your eggs, see what happens, but my advice is to be very conscious of the situation, knowing that if it doesn't work, then you should go for an egg donation directly.
Thank you again, of course, for yet interesting question and yet another great advice here. Next question, of course, interesting one, and let me. Sorry, just yes, here it is. How do you grade the quality? Only morphology, or also kinetics, time lapse, etc.
Yeah, Nuria. So that's a very good question. Both things. If you are using a time lapse, you have to take into account the divisions. Finally, if you had normal divisions, you are going to have a morphological classification. But obviously, if that embryo had abnormal divisions during, for example, the first days, that is something you have to take into account for sure. And maybe if at last you have a very good quality blastocyst, but not very good divisions, and you have other blastocysts to choose, then you will maybe be choosing the one that didn't divide correctly the last. All right. So this is something that you have to take into account for the final classification, which is normally morphologically. But obviously, if there are very bad divisions, let's say, or not abnormal divisions the first days, this is something that we have to take into account in the final classification for sure.
And excellent. Again, thank you so much indeed for explaining. Interesting question indeed. Okay. All right. Let's have a look. Another question. So do you use Dufaston for luteal phase support at your clinic? I've read some sources where they don't recommend it for pregnant women due to possible damage to embryo.
Yeah, normally we don't use Dufaston. For the luteal phase support, we normally use micronized natural progesterone. So, I mean, these are different pharmaceutical combinations. Dufaston is, we don't use it.
Mm-hmm. Okay, thank you for the clarification once more. Okay, and then Angel has one more question. Can sperm with the below result be good for IVF? Semen is 4 to density of 67% and progressive motility of 32%.
The results. Yeah, at first, I would like to have more information, obviously, but at first it seems that it's not a bad sperm count. And for an IVF, we don't need loads of sperm. We can do IVF, as you've seen, we are going to select only one sperm of all normally millions that we have. So obviously, if you have good progressive motility, and I hope that normal morphology, but don't worry, even if you have an abnormal morphology, imagine you have 1% or 2%, is absolutely fine for that, for an IVF treatment, for an ICSI.
Okay, thank you. Okay, when you trigger with both drugs, you give the two together?
Yes, Christina, normally we do give two together, 36 hours previous to the egg retrieval. There are cases where if unfortunately we had, for example, a spontaneous ovulation and we don't understand why this happened, maybe we're changing the timing and giving, for example, these drugs a little bit later, changing the timing, but that's not the normal thing. I mean, normally both of them 36 hours before.
Excellent, thank you for the clarification. One more here. When do you add LH? Menopause?
Well, this is something that it's very individualized in each doctor, but I can tell you that at our clinic, normally we add LH from the beginning. It's true that maybe if you have a patient where you started with only FSH for whatever reason, and you see that the response is not very good, and you want to increase the dose or whatever, we can maybe add that LH effect, like the first ultrasound before beginning stimulation. It's around a 5th day of the cycle, of the stimulation cycle. So, I mean, normally from the start, but obviously there are other options where you can add up menopause or LH effect later on.
Again, thank you so much for that explanation. Okay, let me have a look. Some more questions, of course, are right here. Elizabeth has another one. So are you familiar with dual-stim protocol? And do you have any thoughts on this one and whether it shows better results in women with a low ovarian reserve?
Well, it's something that we're doing quite a lot nowadays because, for example, with patients, that we have lots and lots of patients with a low ovarian reserve, unfortunately. And normally, as I said, we are doing PGS from 38 years onwards. So if we are thinking that we are going to achieve 1, 2, or 1 or 2 blastocysts in each cycle, we do recommend from the start to try a dual stim. I mean, we think it works quite good because the results that we are getting is that the response of in number of follicles, number of eggs finally, is going to be the same as the result that we had in the first cycle or first stimulation, or even a little bit higher. So yeah, whenever we can, we do recommend to go ahead with a dual stim. Another advantage is that obviously you don't have to wait 1 month, one month and a half to go ahead for another stimulation. You go right away. You start 5 days after the first egg retrieval.
Perfect. Thank you so much, indeed. Then,
Thank you.
Let's have a look. And if you can clarify this, do you measure progesterone before the transfer?
Yes. I mean, we measure progesterone before the transfer when we do the trigger, as you've seen, and we do measure it before doing the transfer, for example, after an endometrial preparation, no, a frozen embryo transfer, I mean. Before adding up the progesterone, pessaries or whatever, there are also shots. We do measure progesterone always, even in a natural cycle.
Okay, thank you so much for the clarification. And let me have a look. We will be slowly finishing. I see some few questions left. So if you have more, go ahead, type those in right now. But if not, remember that you can always get in touch with Dr. Santiago and her team at Tambre, Clinica Tambre in Madrid. I'm sure they will be happy to help you out. And if you can take a look at this one, which cryopreservation protocol do you use?
I mean, there's no a protocol for everyone. We, as I said, try to individualize absolutely everyone. If you are meaning which protocol we use comparing antagonist or agonist, as I said, normally antagonist, okay, or as well, it depends on the person. And the idea or the recommendation is minimum, it depends on the age, but minimum try to have between 12, 15 mature eggs so that we can have maximum chances of success in the future.
Okay, again, thank you so much. And Sebastian has one more. How do you trigger before the first oocyte retrieval in duostim?
Well, here you can do single trigger or a double trigger as well, whatever you prefer. There is no inconvenience in, for example, putting HCG before the second stimulation. So you can trigger with whatever you think is going to be best. We do loads of dual trigger in dual stim as well, as we do have low ovarian reserves. We do a lot. Obviously, if you have a patient that has a very high response, a very high number of follicles, and there is a risk of getting hyperstimulation, then obviously only use agonist of GnRH, the capitil normally, so that you don't have that added risk of hyperstimulation. But as I say, you can use both of them if you want.
Okay, excellent. And in your protocols, do you usually add menopur or go with FSH alone?
Normally, we do lots of combined treatments, putting FSH and HMG or LH effect, because nearly all our patients are normally aged more than 35 years old. And we believe that we try to increase egg quality, putting both of the medications. So normally we go with both of them.
All right, thank you. There's one more question that most of the time I know doctors are not really familiar with, which is the fees. So I'm not sure if you can help with this question. If not, I always say that you can get in touch with the Clinica Tambre, and I'm sure customer care, they will be able to help you with more details, right? It's
Absolutely.
always the case. Excellent, that's understandable, of course. Thanks so much. It looks like this was our final question, but of course, as I've mentioned, you can always get in touch with Dr. Santiago. Thank you indeed. It has been very useful and helpful, and I can only say that from the comments I see that you have found this very useful. As you can see, your testing and holistic approach is much more detailed in comparison with my clinic, which was one of the best. Okay, thank you for that comment, indeed. And Dr. Elena, what can I say?
Thank you.
You can see you can see the comments. I don't need to add anything, right? But perhaps you would like to add something before we finish.
No, absolutely. It has been a pleasure being with you tonight. Thank you all. I honestly hope that all this information has helped you. And obviously, if you need any more help, if you have any more questions, please get in touch with us. I will be delighted to help you.
Yes, and I think that someone already actually sent you a message from what I've seen from the previous comments. So thanks a lot for being with us, for your questions, detailed questions, but also very interesting questions, very thorough. So this is sometimes I feel that the doctor has lots and lots of things to think about during the session. So thanks for that. You make it interesting for sure. And Dr. Santiago, thank you so much. Indeed, it's always great to have you. So I'm glad that you are back with us. I'm already looking forward to some more webinars with you. And now, everyone, thank you so much. Have a lovely evening. You know that we will be back here tomorrow at 7 p.m. UK time. We will be back and we will discuss advanced maternal age. So go ahead, sign up. And of course, I hope to see you there. More questions will be answered indeed. And of course, this has been recorded. So if anyone would like to have a look, you can go to our website, My Happy Advances. It will be available tomorrow. And of course, you can find like over 400 IVF webinars on our YouTube channel and of course on our website. I can only encourage you to go ahead and see it. There are some previous webinars with Dr. Santiago as well, of course, right there. Thank you so much. Okay.
Thank you very much.
Your evening.
See you soon.
And I do hope
to
see you soon as well. Thanks so much.
Thank you, everyone. Bye-bye.
Take care. Bye.